Local programming on KRWG Public Media made possible in part by viewers like you. Thank you.
Hello and welcome to Fronteras, A Changing America. I'm Anthony Morneau. There is growing concern about more children getting COVID-19 and requiring hospitalization in the United States. On the program today, we learn more about how kids may be impacted by the coronavirus. Our guest for this conversation is Dr. Glenn Fennelly, chair of the Department of Pediatrics and Pediatric Infectious Disease Specialist at Texas Tech University Health Sciences Center in El Paso. Thank you so much for joining us, Dr. Fennelly.
My pleasure. Thank you.
I'd like to start off. More children are being hospitalized with COVID-19. What age group seems to be the most vulnerable right now with this virus?
It's important to note that children are susceptible to COVID. They can get very sick and they can die like adults. The major difference is that this happens much less frequently. On the other hand, what we've observed since the beginning of the pandemic is it's somewhat older children that tend to be hospitalized. We had a peak week going back a week ago where there was more than 100 children hospitalized. About 60% of those were in the age range of 12 to 15 or 12 to 17. And that's been pretty consistent throughout the pandemic. The difference now is we're seeing again an uptick in the number of children hospitalized and to new peaks.
So with this uptick, what do you think are the major causes for this? Is it mainly just back to school time?
A good part of it is back to school, with children going to school and mixing. In these somewhat older children, they may be participating in sports, and not so much through the sports, but what they may be doing after sports. Again, mingling, perhaps going out socially together in groups. Those are the things we need to guard against.
So with these hospitalizations rising with COVID-19, health officials have said they're also seeing rising cases of RSV, respiratory syncytial virus. What do you believe are leading to these causes of more cases of this virus happening?
It's an excellent question. And what we know is, number one, we were sort of seeing this seasonal variation in RSV. Usually in most climates in the US begins around October, peaks midwinter, and then wanes by April and certainly by May. The peak incidence of RSV in the US was going back to December, early January of 2019, 2020. Since the pandemic, most families have been observing masking, social distancing. That protected most children against transmission of all respiratory illnesses. What we've been seeing since April, May of this year is there's been an accumulation in the number of children that are susceptible or that have never experienced RSV. And as they've, in certain jurisdictions, gone back to school in early August, even earlier than that, letting down the guard in terms of masking, families going out more, that's probably what's led to the spread of RSV.
So do you have more concerns about this fall with this virus?
What we know already is that there have been reports, for example, in Houston, of an increasing proportion of children hospitalized with not only RSV, but a combination of RSV and COVID. In Texas, children started going back to school in August. I think that did serve to help accelerate the transmission of RSV. Perhaps school-age children went home, may have transmitted it to their younger siblings. The peak incidence for hospitalizations with RSV is in the sort of infant or latest toddler age. So yes, I think as more jurisdictions see children going back to school, we may see an increase in both RSV and COVID among children.
Did health officials like yourself really anticipate the rise in cases around this back to school time?
Even during the peak of the winter of 2021 pandemic, we knew we could send children back to school safely if we observed certain mitigation approaches. Among them, obviously, first and foremost, was masking. If you wear a mask, if I wear a mask, that reduces the chance of transmission between us by about 70%. In addition to that, physical distancing, keeping symptomatic children out of school, we know how to do this well. In states where there have been prohibitions on mandates, it's no surprise that many more families are choosing not to send their children to school with masks. Therefore, the increased transmission of COVID does not come as a surprise.
Now, you mentioned there's different approaches. Every state has a different approach to taking on COVID-19. What does the research show us is the most effective way when it comes to schools, preventing COVID-19 outbreaks in schools? What does the research show us?
Number one, ideally, we would have a vaccine that could be used in all age groups. And originally, the mRNA vaccines were more than 94 to 95% effective at the original variants. We know that those vaccines still protect very well against severe illness or hospitalization, including in children 12 and over for the Pfizer vaccine. In the absence of that, masking is the best approach that we have. In addition to masking, as I pointed out, there are several other measures that should be taken. Physical distancing within classrooms, increased ventilation, keeping symptomatic children out of school, and in certain instances, screening for COVID.
Now, you mentioned some different approaches there that research shows us are the most effective. So I'd like to talk with you about something specific, and that is some states have mandated that workers in schools, adult workers in schools, get the COVID-19 vaccine or submit to weekly testing. I'd like to hear from you, how big of a difference can this make if you have all the adults eligible for the vaccine vaccinated in the school?
First, as a healthcare worker, I've always been expected to get a flu vaccine each and every season. Every season requires a new vaccine against new variants. That's because I come into contact with people that are very vulnerable. I could potentially transmit it to them. It's also to protect the workforce. When it comes to teachers, there's evidence that in one instance, a single teacher that didn't wear a mask to a classroom that was COVID positive infected half of the students in their classroom. So that's one example of the potential risk. What are the benefits? The benefits are very clear. The risks in the balance are very few and far between, aside from local swelling, fever, potentially flu-like symptoms from the vaccine, but most of these go away within 3 days.
When it comes to COVID-19 and kids, how does the virus affect kids? Does it affect kids differently than it does adults?
Again, COVID can cause severe illness or kill across the lifespan. Children, particularly much younger children, tend to be less susceptible to both severe disease, hospitalization, and death. Children, on the other hand, are uniquely susceptible to what's referred to as MIS-C. This can occur on average weeks after an acute infection. That infection may have even gone unnoticed. It can involve a high fever, rash, inflammation of the lining of the heart, of the gastrointestinal system. The majority of these children end up recovering. However, it can lead to, in certain cases, prolonged hospitalization. In the balance, about 350 plus children have died from COVID, including from MIS-C. So that's one major distinction. What we don't know is what proportion of children are at risk for so-called long COVID, or what exactly that looks like. It could involve a change in their ability to learn, their behavior. So that's an unknown.
What are we learning in that area as far as determining if somebody has the potential for long-term COVID? Is there any specific signs?
At this point, it could be a general fog, headaches. It's an area of inquiry. And there's also sort of work on just coming up with a standard case definition so different groups can begin to compare their observations.
Now, when it comes to community spread of COVID-19, can you share with us what age group in children and teens is more likely to spread the virus?
With the original COVID variant, it seemed like the youngest children were less likely to transmit the virus. In part, this may have had to do with behavior as well. Teens tend to go out more in groups, socialize more. There were certain lapses in masking. There were spring breaks going back to the first season of COVID. So it's difficult in a way to tease that out. On the other hand, we know that children can certainly transmit to adults. This has been observed even in daycare settings. But the group that seems to be transmitting the most has been the teens and young adults.
If there is a parent, let's say perhaps a single parent who has contracted COVID-19 and they still need to care for their child who may not have COVID-19, what are your suggestions to that parent on how they should adapt to the situation? What are some things that they need to do immediately?
These are the same precautions that we've all taken throughout the pandemic. Number one is the parent could attempt to wear a mask at both times, mask the child depending on their age. Most children 2 and over will comply with wearing a mask. Strict hand washing, and as much as possible during about 10 days or so even, isolate from the child.
Okay. Now, I'd like to hear from you. With the variants that we're seeing with COVID-19, what are your concerns about what we're seeing with the Delta variant and other variants and how that may change the infection of children with the coronavirus?
The major change with the Delta variant compared to the original variant and many other variants is that it's highly contagious. Certain predictions show that it's up to 1,000-fold more, replicates up to 1,000-fold higher levels. It's much more transmissible, at very least 2-fold, if not up to 5-fold more transmissible. So in a setting where there are children coming back to school, if there's not masking and other procedures in place, particularly for the children under 12 that cannot be vaccinated, that's a setup for high rates of transmission.
What are some of the examples that you've seen that seem to be working in schools that are helping prevent outbreaks with COVID-19?
At the height of the pandemic, there were certain schools in the Midwest that sent their kids back to in-person classes, and this was in the setting of very high rates of community transmission. Those schools, again, did what we know works: masking, social distancing, to a degree cohorting children, so they move together throughout the day as a group and don't mingle with children from other classes, keeping symptomatic children out of those classes. Even now, those are the best practices to prevent COVID transmission in the classroom.
What about testing? Are you seeing anything with testing at schools that are really helping slow the spread of COVID-19 or that are working?
Absolutely. If testing is done default in many cases, as many universities have done on all students or sports teams, certain of the school districts in El Paso will do this only for symptomatic children. There's no question that will help avert cases. If a case is identified, that children will stay out of school and be removed. On the other hand, I think the schools that are practicing best practices, in addition to testing, are also encouraging, if not enforcing, masking.
I want to move on and talk about vaccines a little bit now. The CDC is recommending that everyone 12 and older get vaccinated against COVID-19. What would you tell parents who are unsure at this moment about getting their child vaccinated?
In one sentence, if there's an opportunity you have for your child to be vaccinated, do it. The benefits of the vaccine for children 12 and over far outweigh any potential risk or potential harm from the vaccine.
Now, what about side effects with the vaccine in kids that are eligible to take the vaccine? What are we seeing?
The overwhelming majority of children will experience the same relatively minor side effects as what adults. That includes some pain, swelling, redness at the site of injection, a fever, which tends to be lower grade. They may have some generalized fatigue or malaise, as it's called. It only lasts for maybe up to 3 days.
There's been some reports of inflammation of the heart and surrounding tissues following Pfizer and Moderna vaccines. How can health officials better monitor what's happening with these specific side effects and how rare are they?
I'll address, first of all, how rare or how frequent they are. The estimate right now is about upwards of 1 in 15,000 children between the ages of 12 to 17 may be at risk for this so-called myocarditis or pericarditis within a couple of weeks after getting the second dose or the booster dose. In terms of when you compare that risk to the risk of getting these complications from COVID, if a child gets COVID, which is increasingly likely with the spread of the Delta variant, which is much more contagious, that child may have up to a 35 to 40-fold higher risk of getting these compared to children without COVID. And that risk is upwards of 20-fold higher than getting this complication from the vaccine. Whereas it's difficult to compare the outcomes from that myocarditis, pericarditis from the COVID illness versus the vaccine, it appears that the overwhelming majority of children that have the complication from the vaccine get better very quickly.
Now, with the vaccine being available for younger children, what do we know about when we can expect this to be available possibly? And can you kind of give us an update on what's happening with the clinical trials?
The Pfizer vaccine, as we know, currently is approved for children ages 12 and over. It seems to be more effective in certain ways in that age group when we look at the level of antibody when they receive the same dose as an adult. Both Moderna and Pfizer are studying this vaccine in much younger children, in the case of Moderna down to 6 months of age. The most likely next approval we're going to see will be for either or both by, if not late 2021, early 2022. What's happening is that the FDA has requested more data around safety. It's already been established that a lower dose will be as effective, if not more effective, at achieving the same antibody, the protective antibody response in younger children. The question is, we want to make sure that we expand the numbers of children in these trials to ensure that it is safe.
Now, we're starting to talk about booster shots of COVID-19 for some adults who may be eligible. What would you say to parents of kids who may be frustrated that their child can't even get the vaccine yet, and we're already talking about booster shots for adults?
I would say to them, it's important to understand that the availability or access to the Pfizer or Moderna vaccines for younger children, it's not a matter of supply. We do have sufficient supply in the US. The sad part is we don't have enough takers. It's a matter of regulatory approval. And as I said, we need to make sure that the vaccines are not only safe, and the data I believe is there already, that the vaccines will be as effective in the younger children as in older children and adults. We need to make sure that there's no signal that could signal potential harm. My prediction is that these vaccines will be shown to be acceptably safe, and they will have approval within the time frame that I mentioned.
If a child is hospitalized with COVID-19, are the same treatments available for them as adults?
Yes, and the standard treatments now include, depending on the severity of the illness, antivirals, remdesivir. We can calculate age-appropriate or weight-appropriate doses. We may use, in certain cases, steroids in children with severe lung illness, and in the most severe cases, sort of respiratory support.
Okay. Now, there's been a lot of reporting about some people taking deworming medicine after contracting COVID-19. Your thoughts on what are the risks with this?
So that story probably initiated with some reports. There was some anecdotal evidence that they may be effective. Now the consensus is that the compound called ivermectin absolutely is not effective against COVID, and it can cause severe illness. Many of the compounds that are being taken are used at much higher doses. They're preparations for large animals, and we don't know what's in them in terms of the vehicles as well. So these can lead to severe illness, vomiting, diarrhea, delirium, seizures, and in certain cases, death.
How big of a concern is that to you about people taking just word of mouth of what may be working and trying things like that? Do you see that as a major problem during this pandemic?
That has been a problem, and it's become more of an acute problem in the wake of these false reports around the effectiveness of ivermectin. What I think has done more harm is the false reports around vaccination. One prominent example of this is that a relatively common question from parents who have a lot of questions and concerns about the safety of the COVID vaccine for the 12 and over crowd. Will it cause infertility in my son in many cases? That's absolutely false information. There's no evidence whatsoever in either males or females that these vaccines impact fertility. And it's really what I refer to as a vaccine trope. This goes back to polio immunization. You can look in various places over the last several decades. And by sharing such misinformation, you could potentially be denying somebody the opportunity to have life-saving vaccination.
How long have you been practicing medicine?
I completed medical school back in 1987. I've been practicing pediatrics and infectious diseases since the early 1990s.
So when it comes to misinformation, have you ever seen anything like this as it is today in the U.S.?
I've never seen something, certainly in the US, where we had such an imminent threat, a public health threat of the highest level, where people would, if you will, listen to and follow misinformation before doing the right thing. I have seen instances of this in other countries. In the former Yugoslavia, going back to the early 1990s, I was involved with Doctors of the World USA in a polio immunization campaign under the auspices of that organization to reassure the public that that vaccine was safe and that it would not cause infertility. And that helped avert further cases of polio, of which there were a dozen or more in 1994 or so.
Now, what are your concerns, though, with how the medical community and health officials are doing with getting the word out about getting vaccinated? Do you think there can be some improvements with getting the facts and information out there and with communication?
That's an excellent question, and it begins with the question of who do most people trust? I believe the physician or the family physician, the primary care physician, is still the most trusted person that we have contact with. In the balance, I'm very, very impressed with the majority of physicians, certainly locally here in El Paso, nationwide, are giving out good information. They're taking the time to address the concerns. There are a handful of physicians that are maliciously spreading misinformation. But again, that's the absolute exception. I also appreciate the way that certain respected leaders in sports, Charles Barkley recently stepped up and called out some of the current NBA players and just say in words that I can't quote here, just do it. It's the right thing to do. You need to protect your families, your girlfriends, your children, and the children of your teammates by getting vaccinated.
Now, El Paso has had higher vaccination rates than many communities in Texas. Do you think with this being the case for COVID-19 this fall, do you have better hopes for the fall for our region?
Yes, I think when we talked about El Paso County in far western Texas, we have achieved very high rates of adult immunization, more than 70% early on. We were among the few major cities that achieved that point. And I think it's no question that has helped us avert some of the crises that we've seen in Dallas, Houston, and in Florida, where there have been even children or pediatric hospitalizations that have surged. I think through high levels of adult immunization, even if we're not immunizing the youngest children, they're indirectly protected.
So why do you think El Paso is doing so much better than other cities in Texas? Do you think it's because the city was hit so hard last fall?
That's part of it. I came from New York to this area in early August of 2020, where we were hit particularly hard. And I know that the acceptance in New York was moderately good. What I am impressed by here is how everybody rolled up their sleeves when those vaccines arrived. We saw lines that snaked around our campus here between University Medical Center, Texas Tech. Everybody volunteered to immunize. I'm going probably on my dozenth vaccine drive where I've volunteered to vaccinate across the lifespan. And it's really that sense of pitching in. And I think El Pasoans really do champion their health. I'm impressed as well with the proportion of people who continue to wear masks in public. And from what I hear, when they send their children to school, they encourage that as well, despite the fact that we don't have mandates.
Now, moving forward at this point in the pandemic, what is the biggest concern for you as a pediatrician and somebody who's focusing on this specific category? What's your biggest concern right now?
I would put it in two major groups. The first is most immediately some of the questions that you've raised. What's going to happen as more children go back to school? Locally in El Paso, we might see a bit more of a surge of RSV, perhaps more COVID, perhaps a combination of both. Other cities and counties throughout the US are going to see the same. That could overwhelm the hospitals, that could interfere with routine care and care for acutely ill children. In the longer term, I'm concerned on two main fronts. One is, could COVID or the SARS-CoV-2 virus continue to mutate? Will it evade the vaccines? We need to vaccinate as many people as possible, as quickly as possible, to avert that. And in the longer term, I'm concerned about acceptance of vaccines and validated therapies. We need to reset that conversation and get back to a place of reason by any means.
Dr. Glenn Fennelly, thank you so much for joining us for the program.
It's my pleasure. Thank you.
And we want to thank you for joining us for another episode of Fronteras, a Changing America. I'm Anthony Moreno. We'll see you next time.